Good evening, all the aspirants present here. So the topic for today is GI. It is going to be a CBS session, and the speaker that we have here is Dr. Arun Sir. He is a senior clinical fellow critical care at Guy's and St. Thomas Hospital, UK. Thank you, sir, for being with us. Also, aspirants, it's going to be a very interactive session. Do answer in the chat box, or you can also unmute your mic. Any doubt, any queries needed to be solved, you can. Thank you, sir. So you may take over.
Thanks, Padma. Hello, everyone. Welcome. So this class is going to be a session on computer-based simulation for in the topic of gastrointestinal system, and hope you all came prepared. So as Fatma said, I'm working in Guy's and Thomas Hospital in UK as a senior clinical fellow, and I passed EDIC exam after undergoing this course with Farz Academy, and I found it really useful, and it's my turn to help you prepare and clear the exam. So congratulations for being here. You have enrolled for EDIC Part 2 and taken a step ahead in your life. So congratulations again, and you are in safe hands with us. So this session we will focus on CBS. I hope you all have some basic idea about how the CBS exam is. It's basically like a quiz competition in the rapid fire round. So there will be like 10 minutes for you to answer 10 questions. It will be a bit long question with either biochemistry analysis or an image-based question or a graph analysis. Can be of anything from the critical care. So you need to be like thinking fast and answer like you do in a quiz competition. And yeah, this is a good platform for you to practice and speak up and get ready for the exam. So make use of it. I will try to edit your answers as not everyone is trained in UK or Europe standards. So I'll try to do that and modify your answers. So as Fatma said, let's try and keep it interactive. This is going to be a free for all session. So whoever thinks they got the right answer can unmute yourself and answer. I'm not going to go for round robin in this session. And yeah, if you can crack most of the answers, definitely you are passing the exam. I can guarantee you that. Okay, let's start. Yeah, go for it. It's open to you all. Can you all see my slide? I hope you can all hear me and see my slide. Just give me a thumbs up if you can.
Sir, I'm very sorry
Mhm.
to interrupt in the class, but sir, your video is visible in the PPT. So is there any way we can remove that? Because for that the PPT is not like being clearly visible to us.
Is it better now?
No, sir.
All right. Let me share again. Mhm. How is it now?
It's okay now.
Oh, great. Yeah. Yeah, go for it. It's open to the audience.
Ischemic bowel,
Ischemic bowel. Yeah, hang on, correct. And treatment?
surgical treatment.
Oh, yeah. Would you like to expand? So if you answer like this, the examiner will be asking, can you tell me more about it? Unless they get the correct answer, they will give a couple of prompts. Otherwise, they will move on.
Resection of the ischemic bowel.
Resection of ischemic bowel. Yeah. Any other options? It's not wrong. It's absolutely correct. I'm just asking if there are any other options.
Can start with the supportive management, IV fluids and antibiotic and NG tube and start anticoagulant for the patient and observation.
Yeah, it's all absolutely correct.
After that, consultation for surgery.
Yes. And can you explain the findings on the CT? How did you come to the conclusion that it's acute mesenteric ischemia or bowel ischemia?
This ring-shaped opacities, black ring around the bowel.
Bowel edema.
Yeah.
So, yeah, one thing to look out for in CT, especially for this exam, is look out for air in the abdomen, outside the bowel, I mean, where it's not expected to be. So, what you are all seeing, can you see my cursor on the CT? Yeah. So, this
So,
black structure around the bowel, it's the air inside the bowel wall, which is definitely not normal. It can be inside the bowel wall, but not in the wall. So this is called as pneumatosis intestinalis, and it's a late feature of mesenteric ischemia. So if this is present, the patient prognosis is quite bad. And can you see air anywhere else in the CT where it's not supposed to be?
there air in the liver.
So what do you call that?
Hematobilia.
Yes. So it's more, we can see even in the peripheries. If you scroll through all the images, of course, the exam, there will be just a snapshot. You cannot see like multiple images. It will be like a single image. So this can be called as pneumatosis portalis or pneumatobilia. So this again is a very bad prognosticating sign and marker of late feature and extensive bowel ischemia. So yeah, treatment, as you said, is all the supportive management and surgical referral. And not all the cases go for like surgical resection. Some of them like are candidates for embolectomy. So nowadays, interventional radiology procedures are like come up so, I mean, they are so advanced now. So there is option for IR procedure for almost any surgical abdomen. So that is an option as well. And so exactly in this case, what do you think is the reason for ischemia?
Atrial fibrillation related
Fibrillation.
embolism.
Yeah, exactly. And the patient was not on anticoagulation, so potential to develop atrial, I mean, thrombus and it getting embolus too. And based on the territory in the CT image, we can see it's more of small bowel, so it's likely to be SMA, superior mesenteric artery occlusion, causing this ischemia. So usually, if you have seen the cases being managed in ICU, they even if they go for bowel resection surgery, they don't close the abdomen. They keep it open with a temporary abdominal covering like Bogota bag and have a relook surgery within like 24 to 48 hours in case there is extension of necrotic area, so they can redo resection and anastomosis.
अरे उसका लैपटॉप तो दिला लाओ
Any doubts on this? Yeah.
Sir, what is the treatment for pneumatobilia? I mean, anything we need to do for that?
No, nothing specific for that. If it's there, it's almost patient is in the deathbed. So we should
It's a
be,
poor prognostic marker.
yeah, it's a very poor prognosis. It's one of the late markers, late signs to be picked up. So it generally means extensive disease and extensive bowel ischemia. So it's poor prognostic markers, and we should think about redirection of care and palliation and prepare the family for the death. Okay. Moving on. The 38-year-old woman with type 2 diabetes presents with severe epigastric pain radiating to the back. Vomiting, xanthal asthma is noted. Lipase is elevated. Triglycerides are elevated. And glucose is hyperglycemia is there and with severe metabolic acidosis. What do you think is the diagnosis?
Good evening, sir. It's acute severe pancreatitis with edematous pancreas, bulky
Yes,
edematous pancreas,
you're correct, Pankaj. Yeah.
and acute
Diabetes.
therapy with
Yes.
and acute therapies consist of uh, adequate fluid management,
Mm-hmm.
pain management,
Yeah.
Plasmapheresis.
Plasmapheresis. Why do you think plasmapheresis? What's the
Triglyceride,
Yeah, go ahead.
triglyceride level more than 1000 milligram per deciliter. That is indication of plasmapheresis.
So the cause of pancreatitis is probably hypertriglyceridemia here, correct? So that's why you are thinking about plasma exchange. Is there any other like less invasive treatment for triglyceridemia in the acute setting?
Glucose insulin.
Yes, exactly. You're absolutely correct. And with plasmapheresis, the evidence is not great. So it's kind of the last modality of treatment if a patient is refractory and is deteriorating fast. So, yeah, but you are all correct.
Also, sir, insulin should be given in this because diabetic and glucose is high with an iron gap metabolic acidosis.
Yes. So, dextrose, we give it as a combination of dextrose and insulin just to uh, tilt the patient into anabolic state and prevent more free fatty acids. So if you look at the pathophysiology, how hypertriglyceridemia leads to pancreatitis, it's not just the triglycerides level, but it's more of a free fatty acid level, which actually causes the pancreatitis. So that's where the controversy with plasma exchange, whether it's actually has a role or not, because it's not going to reduce the free plasma, free lipids level. It only drops the triglyceride level. So that's where the controversy arises. But in theory, we do use it in a patient is refractory, uh, just secondary to hypertriglyceridemia. Yeah. As you said, there is bulky edematous pancreatitis. What are the other few features you can expect in the CT?
Necrosis, if there's air, it will be necrotic material. And cysts complication also, pseudocyst. And
Yeah.
Necrotic debris.
So I've just put a slide for the expected findings. So here we can see just peripancreatic fluid collection and bulky pancreas, which is like as we see in our case with some pancreatic fat stranding. So always look for fat stranding in the abdominal CTs. Next,
Sir, can you show where is fat stranding?
so usually we don't see the fat uh, as a separate structure in CT. So here, when you see like apart from the organs, like in kidneys, if you see a lot of like there is normally fat around the kidneys, but you don't see it like a specific thing. So this is just like diffuse ground glass opacities comparatively in the lung. Whatever you see is like consolidation pattern in the lungs, just like that around the pancreas here. So that's what we call fat stranding. And any infection, inflammation around a particular organ, we can expect that. So you should look out for that.
And
Apart
sir,
from
where is fluid peripancreatic?
so the fluid is this.
This black. Okay.
This density is the fluid, and here this is the fat structure. And if we have ascites, we can see like similar densities around the liver and even across many organs. Like here, you can see some ascites. If you can trace my arrow. So this is the fluid nature, which is picked up in CT. So that's how it is appearing here. Yeah. And here There is an example of pseudocyst, which is a chronic complication, which we can see in the later stage after a patient presents with chronic pancreatitis or 4 weeks later. And so this is the necrotic collection. And here's some abscess changes going on. And this is a walled off necrosis, which develops after some time. You can see a definite wall around the abscess. All right. Any other doubts? So there are a lot of scoring systems in the pancreas. I don't think it will be asked in the exam. It's easier to manage pancreatitis than to remember all the scoring system. So yeah, move on. 67-year-old woman with fever, right upper quadrant pain, jaundice, confusion, and hypotension. The bilirubin is very high. All the liver enzymes are high. Leukocytosis is there. Hyperlactatemia. What's the diagnosis?
Cholangitis.
Exactly. You're correct. Why do you say it's cholangitis?
Because of the triads, sir, fever, jaundice, and raised liver enzymes, and I can see CBD stones also.
One more important feature. So how do you differentiate it from cholecystitis? Yeah. So what's the important feature which differentiates it?
The
from
cholecystitis will affect the gallbladder, whereas cholangitis is the CBD, where stone infection is present in the CBD. So that.
Yeah, it kind of presents in a
Obstructive
similar.
jaundice.
Yes, Dr. Mohammed?
Obstructive jaundice with fever and shivering. This is charcot-triad.
Yes, exactly. And one radiographic feature which is useful in differentiating is the CBD dilatation. So yeah, look for dilated CBD in the reports of abdominal scans or ultrasound scan. So that's an important differentiating point. And if the patient is clinically deteriorating very rapidly, you should always treat it as like ascending cholangitis, because cholecystitis per se doesn't cause like the systemic bacteremia and shock, but ascending cholangitis should be in the differential whenever the patient is deteriorating or grossly septic. And yeah, so how do you treat it?
ERCB. Drainage is a choice.
Yeah.
So if patient is stable, we go to ERCB. Otherwise, we will percutaneous drainage together with antibiotics.
Yeah, well done. So that's all correct. So urgent biliary decompression is the treatment of choice. If ERCP fails, then we can go for percutaneous transhepatic route or just cystostomy to just decompress the gallbladder. So any doubts with this?
So what is the ideal diameter of the CVD to diagnose it as a cholangitis?
More than 6.
That's a really good question. I think there is no consensus exactly on what centimeter, but if it's more than like 1 centimeter, yeah. Normal, I from what I read, it's like up to 7. It seems normal, but more than 10, we can definitely think of like dilated CBD. Great.
Okay.
Antibiotic of a choice.
Sorry.
Antibiotic of choice for cholangitis.
Antibiotic, so it depends from the center where you're working, and if you think, of course, we go for broad spectrum coverage, and yeah, we can ask like what are the antibiotics which has good penetration, biliary penetration?
Piperacillin, tazobactam.
Yeah, that's one of the
ampicillin.
Yeah.
Imipenem, sir.
Imipenem, it's slightly better than meropenem, but yeah, if it's resistant bacteria, ESBL, then we should go for meropenem, but it doesn't have great biliary penetration. So that's a Good question, thanks. So, yeah. 59-year-old woman with poorly controlled diabetes presents with fever, flank pain, shock, tenderness over the right flank. What do you see?
Right-sided emphysematous
Acute
pyelonephritis.
pyelonephritis, nephrotising, or
Emphysematous.
emphysematous.
Yes, the answer I was looking for. So obviously you can see some necrotizing features around the kidney. So it's a straightforward question. Any doubts on the CT?
Some ascites is there around liver part.
Yes, you can see some peri-inflammatory fat stranding. You can say these bits are a bit inflammatory. And
Other
there's some-
kidney also there's fat. This is fat standing or no? Left kidney.
this is fat definitely around there, but it's difficult to
Not
say.
standing.
Inflammatory, yeah.
Sir,
But
these air fluid levels are normal, this present in the upper part of the CT.
Yes, so intestinal and colon comes here. I think they have given some contrast as well here. So I think that's what we are seeing. And this is normal. If air is within the bowel, that's fine. If it's present outside the bowel or within the wall, then it's abnormal. So management?
Antibiotics.
Surgical consultation, urgent surgical consultation for nephrectomy, possible nephrectomy, together with antibiotics and fluid resuscitation.
Yeah, we start with medical management, but if the patient is not responding, then so nowadays the escalation pattern seems to be like medical management, IR, then surgery. Even if you refer to the surgeons early, they will refer to IR first and see if there is any percutaneous drainage option available because it's less invasive, safer for the patient with better outcomes. And then if nothing is working, then we go for surgical nephrectomy. Let's move on to the next question. So a 25-year-old presents with 24 hours after ingestion of like staggered paracetamol overdose with nausea, abdominal pain, confusion. On arrival, he is drowsy, having astraxis, INR is elevated, AAT is up, bilirubin is up, lactate is very high, creatinine is elevated, hypoglycemic, ammonia is elevated. So they have started NAC infusion already in the ED. So what is the diagnosis? Pretty straightforward, isn't it?
It's acute liver failure due to paracetamol overdose.
Yeah, correct.
And NAC is going to replenish glutathione component to remove the toxic component of the paracetamol metabolite, that is NAPQ. And yes, sir. And according to the King College criteria of liver transplant due to paracetamol poisoning, so patient has INR 3.3.
pH less than 7.3.
Criteria says that sir, if the INR is more than 6.5 or lactate is more than 2 after fluid resuscitation or any 3, like patient has encephalopathy of grade 3 or 4, INR of more than 3.5, or serum creatinine of 3.5, then the 3.4 milliequivalent per liter. These all are the criteria for paracetamol induced poisoning for liver transplantation.
So you got it absolutely correct. Well done. So when there is a delayed presentation, like in this case, do you start an acetylcysteine? How do you decide on it?
I think that the acute until 8 to 10 hours after ingestion can start in acetylcysteine.
And Yeah, so
Sir, it is effective usually within the first 8 hours, but we can give up to 24 hours. It's not that we can't give. So it will be of benefit only by replenishing the glutathione stores.
in this
So
patient, it's
data is
definitely
showing.
liver failure secondary to paracetamol overdose. If it's like suspicious, patient has come with paracetamol poisoning overdose, but there is no organ dysfunction, how do you decide on N-acetylcysteine?
After 24 hours.
By nomogram after 4
So
hours.
your query is after 24 hours or after
No,
8
even
hours?
24 hours. So if the patient is not having any liver dysfunction, has taken a significant dose of paracetamol, do you start blindly or?
So then in that case, we can follow, if we have the history of bolus dose of paracetamol poisoning, then we can follow the Rumek nomogram.
Yeah.
And if the patient Rumek nomogram lies above the toxic range, then we have to start the paracetamol.
Yeah, so whenever there is a suspicion of a significant overdose, we can start. There is nothing wrong in that. And we have can send a paracetamol level, and based on the paracetamol level and the normogram, based on the time from ingestion, we can decide whether patient needs an ACT infusion or not. But when in suspicion or a staggered dosing where we are not guided by the timing, we can always give an ACT infusion. And when do you stop it? How long do you give the NAC and what's the dosage? Can you know?
The dosage is 150 milligram per kg body weight in 1 hour, then followed by 50 milligram per kg body weight in 4 hours, followed by 100 milligram per kg body weight in 16 hours. So the entire regimen is for 21 hours, and we have to stop the NAC infusion once the liver enzymes has corrected, our pH has lower down, our pH has corrected, then we have to stop the NAC.
Yes, and I add when paracetamol level less than 10 can stop N-acetylcysteine.
Yeah. So yeah, that's correct. Whatever you said. And one more thing I wanted to add is like, so the regimen, that's the old regimen, what you said, that is correct, you're bang on. But the new regimen which is being advised is SNAP regimen. So that's a 12-hour infusion. Initial 2 hours you give like 200 milligrams per kilo, then followed by like 100 milligrams per kilo for the next 10 hours. So they compared these two regimens and noticed less incidence of anaphylactic shock, anaphylactic reaction to the N-acetylcysteine. So I think the SNAP regimen, which is a 12-hour regimen, is recommended nowadays. And if the patient continues to have like liver dysfunction, we can extend the infusion for a longer duration, and we can continue till the transaminase level come down below 1000 or INR comes down below 1.5. Yeah. So to refer to that SNAP regimen, yeah, I think I got the doses correct, but refer to it. Yeah. Moving on, 81-year-old post-operative fracture patient with opioid therapy for analgesia develops progressive abdominal distension and discomfort, minimal pain, no peritonism, and X-rays showing this. CT does exclude mechanical transition, and CDF is negative. So what's your diagnosis and how do you manage it?
Sir, it's
Acute pseudo-obstruction.
Very
yeah.
good. Yeah.
Megacolon.
So it's Oglieve syndrome.
Yes,
Or
that's
Oglieve syndrome.
yeah.
Caused in older patients due to opioids exposure mainly, and post-op in post-op patient.
Yeah. So we have ruled out the main like obstruction from CT, and C. diff is negative, so it's going to be a colonic pseudo obstruction. So how the patient can deteriorate and what you will do next if the patient is not like being managed with conservative management. So when do you involve the surgeons?
Total collective.
So what point do you involve the surgeons? Or if you have referred to them, what
Sir,
point?
after the failure of the medical management, if the patient is still have the features of obstruction, like once we have tried for neostigmine and my patient is not improving and is deteriorating, his hemodynamic is deteriorating, then finally we have to give the call to the surgeon.
Yeah, absolutely. And one more factor to consider is the diameter of cecum. So if it's like more than 12 centimeters, then you should definitely consider like surgical involvement. And again, one step before going for surgery is asking your gastroenterology friends to help you with decompression from the colonoscopy. So that's again, there is risk of perforation, but we have to weigh it against the risk benefit ratio and try. And yeah, with IV neostigmine, always we should make sure we are ruling out the mechanical obstruction first before we trial that, and keep atropine ready. Even a low dose of adrenaline might help just to counteract the bradycardia, which can be quite significant if we are just giving the neostigmine without any atropine. In anesthetics, we regularly give neostigmine with glycopyrrolate, right? So if we give it alone, so it's like OPC poisoning features will be there. So we should be careful and ready for that. All right. This is one interesting one. A 42-year-old woman presents to A&E with palpitation and collapses in A&E. So you found this is a rhythm. She was resuscitated, treated with IV magnesium. She ROSC and she's okay now, but she's in ICU. And you found her to have like severe hypocalcemia, hypokalemia, and hypomagnesemia. She also has history of like chronic diarrhea, weight loss, bloating, and dermatitis herpetiformis, and history of gluten intolerance. And further evaluation revealed she was positive for IgA TG2, like tissue transglutamase 2 antibody. Almost gave you the diagnosis. So what is this arrhythmia? What's the mechanism behind this? And what's the
So was it the buoyance and hypocalcemia?
Because had is D pointers.
It's torsid D pointis.
Yeah. And this is a celiac disease, perhaps leading to chronic diarrhea and weight loss, and hypomagnesemia leading to these manifestations.
Brilliant, Priyanka. Excellent answer. Yeah. So what's the mechanism for this torsitis D pointers?
It is reentrant tachycardia.
Routine phenomenon.
Long QT syndrome. Long QT.
Yes, that's what I was expecting. So it prolongs all of them, like low calcium, potassium, and magnesium levels, prolong the QT interval, and prolonged QT interval finally leads to like torsitis D pointers. So that's why we give magnesium and try and shorten the QT interval, and that's the main treatment for torsitis D pointers, isn't it? And of course, you are bang on with celiac disease. I've seen a case recently like this. That's why I put it in intentionally. But yeah, it wasn't celiac disease, but it patient had significant malabsorption syndrome. And the other thing like to look for in these patients is like vitamin deficiencies, like fat absorbing vitamins like A, D, E, and K, and they can have probability as well. So that's how we manage. Any doubts here? Cool. Moving on. We are reaching the near end of it. Two more questions to go. 58-year-old man with decompensated liver disease, fever, abdominal discomfort, hepatic encephalopathy, hypotension. So you're doing a paracentesis, and the neutrophil count is 420, albumin is 9, cultures are still pending. So what's the diagnosis? Pretty much straightforward one.
The diagnosis is spontaneous bacterial peritonitis.
Yeah. And yeah, treatment.
Antibiotics.
We have till culture report. We have to give empirically covering the gram negatives.
Yes. And again, you should think of IV albumin.
Yeah, albumin also.
Yeah. And it also makes sense to put in a drain and get all the acidic fluid out. Sometimes we do that, like a source control. And so how do you differentiate it from secondary bacterial peritonitis?
Polymicrobial, and there will be a cause
Is
for
because of
perforation.
leakage of bacteria from a damaged organ when there is actual breach of the continuity of the intestine. So that leads that's a secondary peritonitis.
When it is associated with a hepatorenal syndrome, then it is considered as secondary.
What was that? I didn't quite catch the last. When it is
Sir, when it is associated with secondary to hepatorenal syndrome.
Okay. No, that's
We
not
can
secondary.
differentiate by culture polymicrobial and serum ascites albumin grade SAG gradient.
Yes. Yeah.
Secondary is the usual peritonitis which we see when there is some breakage or some.
Yes, this is what secondary bacterial peritonitis means, and not secondary to a
perforation. Yes.
So don't get confused with that. But secondary bacterial peritonitis means it's like a perforation or cholecystitis or some other reason for peritonitis, basically. So it's hard to differentiate just by clinical assessment. But if the pain is like too much and not in keeping with just peritonitis, like spontaneous bacterial peritonitis, we should scan the patient, and all the patients who are presenting with decompensation should get a scan or ultrasound abdomen at least to look for secondary bacterial peritonitis. And yeah, so that's how we diagnose it and treat it. Okay.
Sir, what's the dose of IV albumin and what meaning day 1 and day 3?
Yeah, so what do you think is the dose?
0.5 gram per kg.
No, it's 1 to 2
1 gram per kg.
maximum.
Yeah, so on day 1, it's at like 1.5 grams per kilo, and on day 3, 1 gram per kilo. But so that's the textbook answer. But clinically, what I see often is like patient gets 100 mils every 6th hourly or 4th hourly, depending on the blood pressure, and we titrate. We don't like strictly follow like day 1 and day 3, as far as I have seen. But this is what the answer given in the textbook. So for the exam purpose, yeah, that's the answer. Cool. On. It's another interesting case. For medicine, people interested in medicine. A 35-year-old man with resistant hypertension, despite 3 agents, presents with headache, weakness, and polyuria. You find hypokalemia, metabolic alkalosis, reduced renin, and elevated aldosterone with increased ratio of aldosterone to renin. And this is the CT finding. What is your diagnosis?
Conn syndrome.
Conn's disease, hypoaldosteronism.
And Conn's. Yeah, that's as I was expecting. And what's the CT finding?
Suprarenal mass.
Yeah, adrenal tumor, sir.
Yes, suprarenal adrenal mass. Yeah, and yeah, it can be benign or malignant. We cannot just say with this, but yeah, you are absolutely correct. So, what's the common cause for this? What are the differentials with this clinical picture?
Sir, how can we say this is suprarenal tumor? Where is kidney?
Yeah, so This is a like axial cut, right? So we cannot see kidney and adrenal in the same frame, and it's on the right side. So right side is a bit elevated, right? So you cannot see the kidneys. But when you are looking for adrenal tumor, this is the where this is the cut you are looking at, where you can see most of the liver. And when you are finding a mass, just when you are trying to get the kidney, so that's where you find adrenal mass. So if there is a tumor here, you should think it's suprarenal or adrenal mass.
Okay.
So if you get a coronal section, you can see both kidneys and adrenals in the same section, but not in this axial cut. So how do you manage?
What is this in front of the adrenal? Is this gallbladder or what?
You mean
This
this structure
yes.
could be associated with the mass. Yeah, I don't think it's a gallbladder.
This must be IVC.
To be honest, yeah.
IVC maybe, yes.
Yeah, could be. You can see the aorta here.
Yes, this is IVC, yes.
I'm not sure exactly what structure it is,
Hepatic
but
portion of IVC.
IVC. So management. How do you
There is
treat?
control hypertension.
Yeah. And what and
After,
hypertensive?
yes, medication, and after that, maybe resection for this tumor.
Yeah.
So
So if it's like unilateral disease, you can go for like adrenalectomy. If it's like diffuse hyperplasia, both can cause like Conn syndrome.
Can we put pheochromocytoma in differential of this?
Yes, of course. Any patient with refractory hypertension, you should think about a PO as well. But this clinical picture with hypokalemia and alkalosis, high aldosterone, goes more in favor of Conn syndrome. And yeah, pheochromocytoma is definitely in the differential. And medical management, sometimes patient doesn't need a surgery, especially with adrenal hyperplasia. So we just control with spironolactone or any mineralocorticoid antagonist, and that's all the patient. And even if you are going for surgery, you just start them on mineralocorticoid receptor antagonist for like 4 to 6 weeks, optimize the blood pressure and potassium, then you go for surgery. I recently had a case where the patient presented with known to be like adrenal hyperplasia for a long time on treatment, but presented with refractory hypertension and adrenal aortic aneurysm. So yeah, it was interesting. Cool. So going on to the last final question. 72-year-old recent underwent a recent orthopedic surgery. After 10 days of broad spectrum antibiotics, developed profuse watery diarrhea, fever, leukocytosis, high creatinine, and I've given you the diagnosis. PCR is positive for C. diff, and this is the CT. So how do you assess the severity of the Clostridium difficile and proceed with the management?
severe
This
CD
Clostridium difficile.
when associated with fever, abdominal pain, rise in serum creatinine and leukocytosis, and it is a severe kind of infection.
And there will be association of toxic megacolon also. Yes.
Yeah, sepsis and hypotension, shock-like features, then with toxic megacolon.
So with toxic megacolon and sepsis hypotension, what is the grade of severity?
Fulminant.
Yeah, fulminant or life-threatening. And this patient, just with the history, in the severe Clostridium difficile. So what's the management difference? And what are the CT findings? Do you see toxic megacolon here?
Yes, toxic.
I don't quite agree with toxic megacolon. You can measure and see, but doesn't look like a toxic megacolon from just from the CT. So if it's a severe disease, how do you manage it?
IV fluids, bowel rest, and we can decompress the bowel with the help of flatus tube. And then we can give fidaxomicin or oral vancomycin.
Yes. Yeah, I couldn't find any preference regarding like fidaxomicin or oral vancomycin. At least in the UK, it says first line management by NICE guidelines is oral vancomycin, and second line is fidaxomicin. So can either, but in our ICU, we use fidaxomicin for like severe cases as a first measure. So if the patient develops ileus and not observing the fidaxomicin or oral vancomycin, what do you do?
Can use IVIG for the patient
Can give
and
IV vancomycin as oral also, and it can be given as a retention enema
Bulloxamy.
also.
Yeah, retention enema is the next option, and add in IV metronidazole. So that's another option if it's severe and patient is an ileus. And ileus per se is a feature of like life-threatening infection, so you should escalate it further. And what dose do you use the vancomycin and fidaxomicin?
250 milligram 4 hourly for vancomycin, and fidaxomicin is 300 mg/d, I think so.
So oral vancomycin it's 250 QID 6 hourly, and you can increase up to like 500 QID if it's severe end of the spectrum. And fidaxomicin it's 200 milligrams
200
BD,
mg/d.
and all the therapy is for 10 days.
10.
And, yeah, so we have discussed the life-threatening feature.
Vancomycin, I think the 6 doses in a day. It is.
What is that?
Vancomycin, I guess they were 6 doses in a day, 6 times a day.
I'm sure
I'm not sure, but I think 4 hourly is the dose. I'm sorry, I'm not sure.
Yeah, I'm pretty sure it's 6 hourly, but we can check again. I can share a NICE guideline. Don't think I have it. There is, if you refer to NICE guidelines for Clostridium difficile, there is like a nice like table for how to decide on what dose and when do you add in metronidazole or when you
Sir,
switch to
250 QID we start with, but we can increase up to 500 QID. That's, I know, that's 4 hourly, I'm not sure.
yeah.
Mm.
I think that's what I remember too, but we can always cross check. And for life-threatening infection, as somebody mentioned already, surgical review definitely, and try for surgical option. And there is always a problem with the recurrence of Clostridium difficile, right? So that's when we do consider fecal microbiota transplantation. But this is when the patient gets better, goes out of ICU, not in the acute setting. And CT findings, who can describe the CT? Yeah.
I think
Pseudomembranous
edematazole or
colitis.
pseudomembranous.
Yeah, pseudomembranous colitis is more of a colonoscopic like description. How do you describe?
Edematazole.
Sorry?
Colonic wall edema. Edematazole.
Yeah, it's basically thickened colonic wall, suggestive of colitis. And you can see the ascending colon. So here, the ascending colon and the descending colon is thickened. And I think what we can see as a dense structure is the oral contrast they have given. And it delineates the ostrations. These are the ostrations. So because of thickening, the ostrations are nicely seen. And this is what we call thumbprint or accordion sign. So that's classical of like colitis. I'm sure if we have like transverse colon here, that is having colitis features as well. So it's kind of a pan colitis picture on this CT, and it's not hugely dilated. So I don't think it's a megacolon here. So it's just showing features of severe Clostridium difficile. But if there is like cross distension of the colon, then we should consider about megacolon and treat it as a life-threatening infection. Is that okay? Any questions? So we went along these questions in a like slow pace, but actual exam it's going to be very quick, very fast. You just get like 1 minute per exam on an average. So you should be quick to answer and quick to answer accurately, not to waste time. Even if you know the answer very well, just try and limit the answer to like within a minute, including reading the questions, so you don't miss out on the rest of the question. And if you don't know, just don't go blank, just pause the question. You can come back to that later if you have time at the end of 10 minutes. Yeah, so there will be 3 sessions of 10 minutes each. But you will get some time in between the sessions, so you can recover a bit, but you need concentration and focus, stamina to go through all the sessions in a day. So it will be part of the second day of the exam, and you will have 3 sessions of 10 questions each for the CBS. Any questions regarding the examination or today's class?
Sir, thank you for such a nice presentation, sir. And if possible, can you share the guidelines which we have to go through for the preparation for the EDIC 2?
I think you can find it on the EDIC website. There is no particular guidelines, but there is some suggestions like how to prepare. Doesn't say anywhere.
Sir, I'm talking about guidelines from different systems. Like most of the guideline in our country, we are following American guideline in our textbook. Many of the guidelines are American, some of them are European, and so we have some ARDS guideline, then British Trauma Foundation guideline. Then those are the guidelines which we have to go through. So if all the guidelines are in at one place and what we have to go through, then it will be very easy for us to review those guidelines before our exam.
Yeah, unfortunately, we cannot find all the guidelines in a single place. We have to search for each topic, and wherever European guidelines are available, I would suggest like be aware of that guideline. You don't need to strictly follow that guideline, but if for the purpose of European diploma, at least you should know the European guidelines. You are expected to know that.
I have one query. It is not related to the topic that you have covered today, but as per you said that European guidelines we have to follow. Like we have a situation where we have to basically declare somebody as a brain dead, or we are performing a ACNA test after conclusion of the diagnosis. So shall we say in exam that we will perform second test after 6 hours, or is there any difference between Europe? For the exam point of view only, I'm telling.
So yeah, so you can just say like from country to country, these guidelines vary a bit. So what you need to be aware of is like how the guidelines changes a bit and what's the reason behind it, rather than just like being very accurate on the numbers. If you get what I mean, you don't need to go too much into the details, but you should be aware of why the guidelines are like this. Like you can do a review yourself, like this guideline saying like this and this guideline saying like this, and it varies from country to country depending on that factor. So it's a valid answer. And they try to avoid controversial questions, like which varies between different guidelines. So you can just point it out like this guideline say like that and the other guidelines say like that, and it varies from country to country.
Thank you, sir.
All right. Hope you all have a good evening.
Sir, can you show us that first 2 questions, sir? I just missed. Yeah.
Yeah, first question was basically mesenteric ischemia.
Okay, sir.
treatment question. Second question was pancreatite. And we discussed the treatment for hypertriglyceridemia and used pancreatite.
Okay, sir. Thank you, sir.
Cheers. Okay, thanks everyone for joining. Have a good evening.
Thank you so
Fatma, I think we can close the session.
Thank you, sir.